Jenny. Sorry, I didn't realize the mic was on. I wasn't just calling you. Sorry, there's no rush. Just pouring you a glass of water. For some reason, this is not the easiest room to find, or at least I didn't think so. There you go. There's some water. There's your.
Gosh, it's bright.
Are you okay?
Yes. I didn't get to go around all the posters.
I know, it's no rest, is there?
Right. Just get a pen.
Well, good afternoon, everyone. Thank you for sticking around. I know it's been a very busy couple of days, and it's really lovely to see you all in person again. And for those of you that I've not had the opportunity to meet before, it has been very lovely to actually get to see that we've all got legs, because it's been odd thinking with all the Zoom calls to think that there's a whole person behind that screen. So it's been lovely to see you all, and thank you for joining us today's session. I will be one half of the chairing team. And my name's Aidan Seeley. I'm a senior lecturer at Swansea University Medical School. I've done quite a lot with the Society for the Early Career stuff, particularly ECPAG, which sounds like a skin condition, but is the Early Career Pharmacologist Advisory Group. So it really is a pleasure to be chairing for today. And I'll pass over to my co-chair.
Hello, and my name is Jennifer Koenig. I'm at the University of Nottingham, but I'm based in Derby. So I'm the lead pharmacologist for graduate entry medicine and BSc in medical physiology and therapeutics. So I go back a long way in the society, but I guess my two main interests are teaching maths and stats within the context of pharmacology and biosciences, and more recently ethnicity and how we understand that in relation to pharmacology. But we've got a fantastic series of talks going on today. So I'll hand back to Aidan.
And I will introduce our first speaker. It's my pleasure to introduce Claire Gilding, who's going to be talking on the IU4 Pharmacology Education Project, a global site for educators and learners. So thank you so much for joining us, Claire.
And it's very bright. Fabulous. So let me just check whether this advances it. It does. Brilliant. Okay, so can you hear me if I'm actually not behind the mic, or should I go behind the mic? No, you can hear me. There's so few of you and you're very close to me. So I'm going to be talking about the IU4's Pharmacology Education project today. An IU4 Pharmacology Education project was set up in 2016, and that was with generous funding from the American Society of Pharmacology and Therapeutics. And it is the idea behind it was that we wanted to try and establish a site where So this one here where it says drug efficacy and potency, if you were to click on that, that takes you through to the interactive clinical pharmacology website. So this is an excellent website that is produced and hosted in New Zealand. Here we've got different models and teaching around efficacy. You can slide, bars up and down. It will show what the effect is. So links out to other freely available resources. It contains a lot of embedded videos. So these are like PowerPoints with voiceovers, lectures developed again by the editorial board and contributors. So there's within the clinical pharmacokinetics section, there's a really wide-ranging, excellent number of videos which have been created by Simon Maxwell. So Simon Maxwell is one of the directors, along with John Sarek. So they were sort of the initial directors, and they work on a management team with me as the deputy director and Elena Ficenda as the curator. So Simon is a professor of clinical pharmacology at Edinburgh University. He's one of the driving forces behind the prescribing safety assessment, and you can basically access a very wide number of his lectures that he gives to the Edinburgh students. He's created these resources and these videos for use on PEP. So you can go read them, you can direct my students towards them. Yeah, they're excellent. Oh yeah. money to basically fund our curator, Elena, who manages the database, coordinates and curates the submissions. We've got a Twitter. At Pharmacology Ed, if you want to go and have a look at it. So, we advertise some things through that occasionally, but I think we need to do a bit more. And one of the things we're looking at is whether or not we can bring on somebody young and enthusiastic to manage our social media accounts, because I don't think we're doing as much in terms of communicating like that as we should be doing. So in terms of the opportunities, well, I really think that it's a venue to foster collaborations and partnerships among the international pharmacology community and among international pharmacology societies. This is a screenshot here from a meeting we had last week with our PEP editorial board and our IUPAR education section. So this was a PEP-focused meeting. And we have leads from quite a number of major pharmacology societies and also additional collaborators spanning, we've got Hungary, Japan, America, Nigeria, Singapore, wide variety of places on there. So there's also opportunities for you, your colleagues, your students to contribute to PEP, either as editors, so reviewing some bits of material, or by contributing material and resources that you already have. An example of the areas where we're currently looking for more materials for PEP is we're producing what we're calling so far a core teachers section. So this is a section where people talk about seminars that they have developed. It's almost like if you were giving a seminar and you were doing a seminar handover to somebody and you explained who the students were, what it was for, how you would teach it. So we're developing some online resources and packages to do that. But some of the other ones you can see here are areas that we need a little bit more population of. So if there's somewhere that you see and you think, oh, that's what I can do, come and speak to me, and we'd be very happy to have any submissions from you. And we can provide information and feedback to you on the content that you have added, so you can evidence the impact of your contributions. So just to conclude, PEP has got the potential to significantly enhance pharmacology knowledge across many disciplines worldwide. But as a management team and editorial board, we can't do it ourselves because of our limited capacity. So really we do call upon the international pharmacology community to help engage with us and to help make this endeavour flourish. So have a look at the books there, go to the site, look at what's available, use it, direct your students to it, and if you would like to contribute to it, you can follow that web link below. Thank you.
Thank you very much, Claire. We have time for some questions if anyone would like to ask some questions. So perfectly timed with the lights there. Thank you for that. If you can come to the microphone.
Thank you, Claire. Great talk. One of the questions that I always ask myself is when we're making resources like this, what impact does it have on students? Have you got any evidence that people who access these resources do better either in their BSc or in their medical prescribing PSA skills assessments or anything like that?
We don't have evidence like that. I mean, that's kind of the holy grail of any education, isn't it, John? It's like you do something and it's going to make them better. It's very challenging to do, but we do have lots of examples of how it's being used in different activities. So my colleagues over in Monash in Australia use lots of it quite heavily within some of their own pharmacology seminars. They've integrated topics and activities around it. We've got colleagues in Leeds who run capstone projects who are getting, so final year projects, getting students to develop resources for it, which is furthering their knowledge of that topic area, but also furthering their knowledge of education and then, hopefully other people's education. So no, I mean, it's the holy grail in terms of I do this and here you show them it's better. So we don't have that, and we do have examples of how it is being used and integrated into various teaching activities.
Thanks.
Excellent. Do you have any questions?
I have one question about licensing. What stops somebody else coming along from grabbing stuff off there and pretending it's their own and putting it on their own website?
So it's got a Creative Commons license, so they can use it if it's being used for free educational purposes. Yeah.
Excellent.
And then you go after them with a lawyer.
If we find it. I've not come across that yet, but yeah, we'll cross that bridge when we come to it, Jenny.
It really is a fantastic resource, so massive congratulations to you and the team. I personally find it very useful when I'm wanting to make sure that what I'm teaching is up to scratch, and knowing that everything's been reviewed by far smarter people than I always fills me with confidence to know it's on the right track. But it really is brilliant. So if anyone's not used it, I'm not sponsored by any way, but
We're not sponsored.
but thank you so much, Claire.
All right, thank you very much.
So it's my pleasure to introduce our next speaker, David McMaster, who's going to be talking on keeping antimicrobials working, an e-learning resource. So thank you very much for joining us. The stage always feels very long. The stage feels very long when people are arriving.
Hi there, my name's David. I'm a F2 doctor down in London, and today we're talking about the Keep Antimicrobials Working e-learning resource that we've put together. So, antimicrobial resistance is one of the greatest threats to the future of healthcare, and for us as healthcare professionals, it's going to be one of the biggest challenges that we face across our careers and in our lives, and something that I'm sure everybody in the audience is aware of, and is something that's probably been discussed at great detail at this conference already. These infographics produced by Public Health England in 2015, I think, are a really good way of summarising the threat that antimicrobial resistance poses both locally and globally. So here in 2015, there's data that says that 1 in 3 patients in hospital in England were on an antibiotic. And we can see increasing rates of bloodstream infections caused by organisms such as E. coli, Klebsiella. And we can see the global burden of antimicrobial resistance both on number of deaths, so there's estimates of 10 million deaths by 2015, but also the economic burden that antimicrobial resistance poses. This, again, is a slide that I'm sure many people will have seen already, but it does a good job of highlighting the difficulty that we've had in producing new antibiotics and antimicrobials in the last 30 years, despite increasing rates of antimicrobial resistance. So we're getting this situation where we have all these superbugs, but a very limited formula of antimicrobials to treat them. So the World Health Organization Global Action Plan on Antimicrobial Resistance sort of highlights the importance of including antimicrobial resistance and stewardship in the training of healthcare workers, and for a very simple reason that injudicious use of antimicrobials can be caused by a multitude of factors, but also simply just by a lack of knowledge and awareness of antimicrobial stewardship principles. So we already know that in the UK, the vast majority of postgraduate training curricula have very limited exposure to antimicrobial resistance and stewardship, including in those specialties that have the highest use of antimicrobials, so primary care, as well as specialties, particularly hospital specialties that have high rates of use of broad-spectrum antimicrobials and hospital-acquired infections. So in this study in 2016, 37 specialties were assessed, and about 0.3% and 0.4% of topics and learning points, respectively, were related to AMR and AMS. So they could conclude that the coverage of antimicrobial stewardship and resistance was poor across the majority of UK postgraduate training curricula, with little depth of learning required. And if we go one step back behind postgraduate training at medical school. So medical school is designed to prepare the doctors of tomorrow for clinical practice, but there's good evidence that final year medical students have limited confidence in prescribing antimicrobials, despite these being some of the most commonly used medications. So I'm an F2 down at St Mary's, and on a daily basis, myself and all of my colleagues from F1s up to consultants are prescribing antibiotics, following guidelines, and it'll be the same across the country. So in this study, for example, they looked at the median time that UK medical school courses dedicate to AMS education, and it was just under 18 hours, which is less than some of us will probably binge on Netflix this week. It also shows that only about 70% of medical schools are teaching all the recommended AMS principles. And then almost 40% of UK students want more education on the prudent use of antibiotics. And this study that was published in 2018 goes one step further. So it looks at both UK and European medical students, and it just sort of highlights that this isn't an isolated problem in the UK, that medical students across Europe feel that they need more education on antibiotic use. In the same study, they showed us where do medical students feel the least confidence in prescribing antimicrobials, and it really does centre around the AMS principles, so things like deciding when to switch from IV to oral, knowing when to identify identify indications for combination therapy, and then when to prescribe the shortest possible duration of therapy for specific infections. So what can we do? So this paper was a joint BSAC, Health Education England, and Medical Schools Council initiative to develop a consensus-based competency list for UK undergraduate medical education. So we looked and we identified that a national undergraduate curricula for antimicrobial resistance and stewardship was required to standardise an adequate level for all future doctors. So our objective was to develop a national consensus on competencies for antimicrobial resistance and stewardship. We used a Delphi method where we had 25 experts representing leads for infection across UK medical schools, and then from that we had a fantastic response rate of 100%, and on the second round survey we were able to generate 58 consensus descriptors across 6 overarching domains. So what can we do with the consensus-based competency descriptors that we've identified? Well, the hope is that we would be able to use them to inform standards, to design curricula, to develop educational resources and assessment tools, and to direct UK undergraduate medical education. And the focus of today is really on the development of educational resources and assessment tools. So we have created a website, which if we could go to, please, that would be fantastic. So this is a free-to-use website that the Keep Antimicrobials Working Initiative have produced that caters to lots of different learning styles. So if you can see on the left at the minute, we have resources for medical students and junior doctors, some top tips which cover some broad areas, including basic concepts in bacterial antibiotics, starting an antibiotic, antimicrobial resistance. Maybe if we could open up the starting an antibiotic tab, we can see the information that's linked there. So we have lots of information on how to identify when it's appropriate to start an antibiotic and when to stop, including signposting to some useful apps and resources, including papers which have formed part of the guidance. On top of the top tips and educational resources, we also have interactive cases, so for both children and adults, some really fantastic stuff which has been developed by the wider Keep Antimicrobials Working Group. We have some animations that have been developed with Merck on antimicrobial stewardship, antimicrobial resistance, infection prevention and control. I won't subject you to them now, but we've also got some other stuff on there, including some signposting to some apps that we've created, some useful publications which have helped generate the web page. And then also, if we could go back to the presentation, we're really pleased that we've been able to work with the British Pharmacological Society to generate a box set of 15 questions that is being hosted on the prescribing safety assessment platform. So the PSA, the exam that all medical students will sit before they graduate as doctors to ensure that they can safely prescribe, has now this bespoke box set of questions which specifically focus on the principles of antimicrobial prescribing and stewardship. So, for example, this question looks at appropriate source control and use of antimicrobials. And then we're really happy that last year we were able to offer the UK Medical Student Essay Prize, where we had some really high-quality entrants with some really interesting essays on the topic of can medical students do anything useful to support the AMR agenda. And I think the winner of that was given entry to the BSAC Spring Conference and received a certificate and some points for their portfolio down the line. So if there's any medical students in the audience, please do check in to see what this coming year's essay title will be, which we'll be releasing soon. So to conclude, we know that preventing the rise of antimicrobial resistance requires multifactorial interventions, collaboration between healthcare professionals and continued learning. We know that in the UK there's limited coverage of AMS across most postgraduate training curricula, and what we've done is generate consensus-based competency descriptors to help inform standards, design curricula, and as we've shown here, develop educational resources and assessment tools. So hopefully the Keep Antimicrobials Working e-learning resource will be able to help support student learning in one of the most important topics in modern healthcare. And what's next? So it's essential that the principles of antimicrobial stewardship and resistance are embedded into all healthcare professional training. So the Keep Antimicrobials Working undergraduate program currently has streams working to develop competency descriptors for dentistry students, nursing students, pharmacy students. And then for medical students, we're also working to ensure that in the upcoming MLA exams and also in the PSA, we can have as much antimicrobial stewardship knowledge reflected in those, as well as providing resources for educators that will help standardize a larger amount of learning for medical students. So thank you very much, and if there's any questions, please let me know.
Thank you for an excellent talk, David. Does anyone have any questions from the floor? No? Oh, yeah.
Yeah, more of a comment, really. If you ask a medical student what they would like, they always want more teaching on something. The challenge from the people setting the curriculum is often to decide what to include and what not to include. So, do you have any way of comparing the data you showed before about students wanting more teaching on particular domains? Is that the same if you ask them about something else at all?
It's a very good question. I think the crux of the question is how do students best learn? And having finished medical school 2 years ago, I have to say I can't remember if the number of lectures I attended was on one hand or two. So almost everything that, particularly for my finals, that was useful to my revision was online resources, particularly web pages that have been developed by other medical students and using their notes. So things like Zero to Finals, which was really the sort of gold standard for us. Hopefully, by signposting people to this resource, they may not even need to ask for any more in-person, face-to-face education, and simply they'll have a top tips list that they can learn in a couple of days that they can then refer back to when they're junior doctors. And it's something that I've used, hopefully not daily, but definitely lots of times, particularly when I need to find like an antibiogram to work out what coverage do I have with certain antibiotics. And it's just not something that I think is particularly well signposted whilst at medical school.
No, I agree. I think it's a lovely resource.
Thank you.
I think it looks like an excellent resource, and I was wondering what you're doing in terms of getting it known. Obviously, you've got 25 people you surveyed. I don't know whether that included anybody from Newcastle or not. I was just wondering.
I think it was Ashley Price.
Say again? Oh, yeah. Oh, yeah, no, he's brilliant. I'm just thinking it's the sort of thing that we could even put into the earlier years. So obviously, he does a lot in years 3, 4, and 5, but it's the sort of thing I like to kick our students off early with. So what are you doing to make sure that we as educators know that this is a resource that's out here to flag to the students?
Yeah, absolutely. So at the minute, we actually just missed the last meeting we were meant to have on Monday because too many people were either morning or off. But the hope is that we can disseminate it through infection leads and trickle it down through the medical schools to make sure that at least it's being signposted during lectures. The other thing that we wanted to do was to add it to microguide. So on one of the opening tabs of microguide, you have a little section where it says the background information on antimicrobials available at the Keep Antimicrobials Working Resource. So hopefully we can attack from as many as many streams as possible. But yeah, very good question, and it's always going to be the biggest issue, which is how do you implement resources that you've created. Always good to network at events. Thank you.
Is there any other questions? Excellent. I think that perfectly encapsulates what pharmacology is about and getting that networking. So it really does look like a fantastic resource. So excellent work. And I'll be signposting myself to it so I can learn a bit more about it. But excellent. Thank you so much for your talk. And I'll pass over to my co-chair now.
Okay, so the next speaker is Patience Nimozima. I hope I pronounced that correctly. And the title of the talk is Visibility Matters, an inclusive learning and teaching resource for pharmacology and pharmacy. And this is Patience with Jacob Wright from King's College in London.
Hello, I'm a bit short for this one, so I might venture out. Can you all hear me? So, good afternoon everyone. My name is Patience Nimozima, and today I'm going to open a conversation about learning while doing my work on my script source book that I co-wrote with my supervisor called Pharmacology. So, I'll start by introducing myself. I am born in Uganda and grew up in England, which is in accent. So done by the Royal Society, and it showed that only 80% of academic staff in STEM are from women or minorities. Research carried out by the National LGBT Survey in 2018 highlighted that LGBT plus people with LGBT plus background are experiencing higher rates of dissatisfaction in the care provided by the National Healthcare Service, and also that UK scientists
Thank you very much, Patience. That was really interesting. Are there any questions from the floor?
I have some.
Oh, we've got one over there.
Oh.
I could just see.
I'm glad that you're here because my next point was going to be to say, have you spoken to Nick about this? Because this morning the presentation was on how do you get people to see themselves in other scientists, and I'm of the opinion as well that you cannot be what you cannot see, and having those role models is essential. So I think it could be a very valuable resource to be shared, and I'm surprised that it's not been shared more widely. I think what we've seen is fantastic. So it's a very powerful resource for people, I think, so, or it will be. So how do you plan on sharing it? How is it going to be disseminated out? And are you going to submit it to PEP?
Yeah, so I mean, this is my body. It's the British Pharmacology Society. I would love for it to be published and for it to be accessible, maybe on the website or just maybe to like the universities, and this could be a resource that be put out there. So I'm ready.
I do believe that we could get it on the website. I think that would be an excellent resource.
Make a recommendation. Are there any more questions from the floor?
Fantastic.
Okay, thank you very much, Patience.
Oh.
No, there's one more.
Oh,
sorry.
oh, do you have a question?
One more. I didn't see that.
No.
Anything that surprised you other than the lack of information out there? Was there any kind of unconscious bias that you kind of uncovered in this project that you are now reassessing as time goes on?
Yeah, so quite a lot of scientists from LGBT backgrounds don't wish to be identified, which I thought, I'm like 21 and do see a lot of pride, and I thought, that wouldn't be the case. But yeah, some of them do feel like, coming out will affect their careers or their profession and their progression. So that was really quite surprising for me because I don't see that in my generation.
I think there's a way to go. But no, excellent work. It's really exciting.
Thank you. Okay, so our next and last speaker is, I hope I pronounced this correctly, Prashant Nupen, and the title is How Safe and Effective is Non-Electronic Prescribing in the NHS?
Thank you.
Apologies for that pronunciation. You can correct me.
Hello, everyone. Good afternoon, everyone, and thank you for being here. I'm Prasant. I work as a junior doctor in Leighton Hospital. Currently, I'm in medical education fellow, but I was in critical care when I did this audit. It's a very simple, small audit that we did in critical care. As our hospital is still doing the paper prescription, I wanted to do an audit on how safely and effectively were we doing prescription writing in critical care. So prescription writing is really important in clinical practice. Even the small mistakes can lead to minor to sometimes life-threatening conditions, sometimes death of the patient also. So we want to find out in which areas that we are doing good and in which area we need to improve. So that was the basic idea on doing this audit. So I'm showing a couple of papers that was presented in 2007 and 2012. This was the paper from 2007, Royal College of Physicians of Edinburgh, where the medication errors were, paper on medication error were published. So we can see that 36,200 prescriptions were basically studied in this one, and 1.5%, which is around 500 prescriptions, were found to have errors, and 25% were quite serious errors. So yeah, this is the next one, which was done recently in 2012 across 9 hospitals in Northwest England, and 4,238 prescriptions were evaluated in this one. And we can see that 43.8% prescription were had one or more errors. And the errors were calculated basically on these dosing errors, writing errors, allergic status, and multiple things. So basically, we wanted to see how we are doing on that area. So the aim of this audit was to see how safely and effectively we were doing prescription in critical care. So the standard was from our hospital medicine policies, and also as a reference, we took writing safe and effective prescription in hospital cardiacs, which was published by Royal College of Physicians of Edinburgh in 2007. And basically, it was a similar kind of theories behind both the paper. So, like I mentioned, it was very small audit, as we don't have much patient flow in critical care. One patient might stay for a longer time in critical care, so we have very limited resources. So 20 prescription charts were studied on different days over the period of 1 month. We randomly selected the prescription chart, and we randomly selected the days when we wanted to do the audit. And the pro forma for this audit was presented by the Pharmacology department, and 16 subheadings were included in this audit. And the data collected were from new admissions, short stay, and long stay patients. So I've divided the outcomes into 3 different headings just to make us easier. So green, amber, and red. So green is the area where we're doing completely fine. Amber means we need to be a bit more cautious, and red is the area that we were not doing quite good, and then we wanted to act quite quickly on those areas, basically. So yeah, so these were the areas we were doing good. So in all the prescription chart, 3 patient identifiers were basically kept, and 100% medication was prescribed the prescriber. At least there was a signature, but again, we didn't know. We missed out the name of the prescribers, which we'll show in the next page. And dose has been correctly documented in 19 out of 20, and route of medication was prescribed in 18 out of 20 prescription chart properly. And all the medication described at specific doses, like if the medication was given based on the weight or milligram per mils, something, it was properly done in 18 out of 20 prescription chart, and out of 2017 prescription chart has approved generic name medication prescribed, and in 3 prescription chart we found out that the medication were not prescribed on based on generic names. And in 15 out of 20 weight was recorded, and also sometimes we have multiple medications like gentamicin or warfarin, where we have to prescribe it in different prescription chart, but it has to be mentioned on the main prescription chart so that we don't miss the dose. So it was properly done in 15 out of 20. So basically, I have included more than if we have more than 75% information, then I have included it in green zone. So just to give an example, so if the warfarin is prescribed in the next dose, but it should be also written in the main prescription chart, and it has to be mentioned in the front of the prescription chart also. So it was done properly in 75% of the wardings. So this is the amber zone now. So areas where we need to be a bit more cautious. So out of 20, 14 prescription chart had allergic status fully documented, and start date of medication was written in 13 out of 20. So 7 prescription chart missed 1 or 2 start date of medications in those prescription chart. And cancellation were done correctly in 11 out of 20. And alternation also was done in 13 out of 20 prescription chart. So this is the proper way of doing the cancellation. If we want to stop the medication, we need to signature it and also put the date on when we stopped it. Maybe it's better to write the why we stopped the medication. And coming to the red zone. So we found out that only 15%, only out of 20, only 3 prescription chart has all the prescribers that prescribe the medication were identified. So basically out of 20, 17 prescription chart has missing prescriber's name, registration number, and signatures in this prescription chart. So as you can see here, we need to write the name, the registration number, and signature, to properly identify the prescribers. So we don't want anyone coming to the critical care and doing the prescription, and we don't know who prescribed the medication. So in that case, if there is some kind of legal issues also, that will be a problem. We don't know who prescribed the medication. And so in that case also, this is really important. These were some of the signatures. So I cannot say who prescribed the medication based on these signatures. So, yeah. And indication and review date of antimicrobials. So it was only done in 1 out of 15 ORXs. 5 ORXs didn't have any antimicrobials prescribed, but out of 15, only 5% had either indication or review date, or both of them were missing, or one of them were missing. And patient name was recorded on 15% on all the areas where it is indicated, because if we miss any page of the prescription chart, either the patient will miss the doses, or if we confuse between 2 of the patient, then one patient might get different medication which is not indicated. So it was also really important to consider. And finally, the units has been documented correctly in 35% of the prescription chart. So unit means we have to, we only write abbreviation for gram and milligram. So micrograms, we don't use abbreviation. For units, we don't use only U. We need to write units properly. And also avoiding decimal points. If the medication is in 500 milligram, we have to write 500 mg, not 0.5 grams. So this kind of units were documented properly in only 35% of the prescription chart. So 8 areas where we had a green, where we were completely okay. And this is the summary based on our data collection. So we presented these findings in the MDT, critical care MDT, and we discussed on how we can improve this one. So the temporary plan until we get the digital prescribing. So digital prescribing is basically, it's on its way, but it is taking a long time in many NHS trusts. So we wanted to discuss what will be the temporary measures that we can improve the prescription writing in the hospital. So first of all, we did all the presentation for junior doctor, middle grades, and consultant, along with the nurses and pharmacists. Pharmacists were really actively involved in this project. And we decided we'll do the regular audit, at least twice a year in the critical care, based on how we are doing well or not in the prescription writing. We formulated that there was a trust mandatory competencies on prescribing, which nobody knew about. So we made it mandatory so that everyone will be aware of the prescription writing, proper prescription writing. This was the poster we made, and we basically put it along the bedside of all critical care, so critical care bed. So around 12, 13 posters were kept in the critical care so that everyone will be aware on the weak areas that we definitely need to improve so that they can see this poster and then try to do better prescription. So yeah, so long-term plan, which is a digital prescribing, was discussed. And I think digital prescribing is, has been on the plan, but due to the COVID and all the situation, there has been delay from the government or NHS. So I think if we have a digital prescribing, then most of these issues will be resolved. Suppose the identification of the prescriber will be known, and indications and everything can be known for antibiotics or antimicrobials prescription, accuracy of the dose units. So all these kind of errors can be dealt with digital prescribing. So since 2018, 216 NHS trusts have received some kind of funding for their digital prescribing, but there is no proper data on where we are at the moment. So out of 219 NHS trusts, 216 NHS trusts were believed to get digital prescribing by 2021, but we don't have any data at the moment on how many trusts are using the digital prescribing. So this was the target, at least to improve in all areas, at least to improve by 80%. I have not included the result, but we managed to get 80% in most of the areas, apart from one, which was we could not identify the prescribers who was prescribing the medication. Basically, they forgot to write the name and signature in front of the main prescription chart. So we got around 50% prescription which was done correctly. So apart from that, we got more than 80% in all the areas. So that was a good improvement. So yeah, thank you so much for listening.
Thank you very much. That was very interesting. Are there any questions from the floor?
I have a question. So, quite alarming that there's quite a few errors and issues with that. Were they reported? So, obviously you're trying to raise awareness, but I was at a poster presentation during lunch and they were talking about the lack of reporting of prescription errors. So what is the process? And have you encouraged your colleagues to report?
Actually, we did it in the MDT meeting of critical care. So all the consultants were present in the MDT meeting. So it was escalated quite nicely. And all the senior nurses and pharmacists, all of them were involved in the process. So it was escalated, and it was decided that we will keep an eye on these errors. And every day we used to check the prescription chart properly since that day. So as we got good results in the next audit, re-audit, so I think it was not escalated to that level, but inside the critical care department, this was escalated. But we found out that from the pharmacist, we found out that all the other wards or departments in the hospital, they were doing more wards than what we have in critical care. So critical care is a very controlled environment, and we did it properly, but it's difficult to manage all in the hospital, all over in the hospital.
Is it a question?
Hi there. I've got two. Is two all right, Aidan? Jennifer? First one, quite shocked by the unit changes when people were describing weights of drugs to be delivered. Presumably it should be consistent, right? And are there fines and processes for writing 0.5 grams instead of 500 milligrams, for example?
So, sorry, I couldn't get your question.
It's about fines, basically. Couldn't there be some sort of process for making sure the department can't prescribe, or some sort of going back to do CPD? Because you want to make sure that the units are consistent, so minimise the errors. Is there processes in place to make sure that that doesn't happen?
Yes, so all the new doctors who were enrolled in the hospital, sometimes the doctors come from abroad and sometimes from other hospitals. So we made mandatory requirement to complete this mandatory prescription CPD course before they join the proper clinical practice. So in that way also we did good, I think, in the second part of the audit. So.
Thanks. The second one's about electronic prescribing. Is that coming in your hospital, and would that help minimise the errors, do you think?
Yes, it will definitely help minimizing the error, because we will know it will be a very controlled one. We have been hearing that we'll get digital prescribing from 5 years, and some of them has been mentioning that from 6, 7 years it has been on the process. But I think we recently found out that by 2024 it will be there in our hospital. So we are looking forward to it. I think our hospital, as it is a district hospital, we have not thought much of those aspects. But I think we try to do it within our department, with liaising with the pharmacy department. So I think a pharmacy department are really working on this area. They have been really struggling, to get the good, proper, safe and effective prescription within the hospital. So I think there was a proper plan from the pharmacy department, and they are working on that. But I have not been made aware of this thing.
That's great. Well, thank you very much for that presentation.
Thank you so much for.
So that brings us to the end of today's session. So a massive thank you to all of our speakers, and also a massive thank you to all of the BPS staff and the technical team who've been working wonders behind the scenes to make sure this all goes seamlessly. But thank you very much to our speakers. Thank you very much for attending. And I do hope you enjoyed the very end of Pharmacology 2022. Thank you to my co-chair, Jenny, and have a wonderful, safe journey home. And we look forward to seeing you at World Congress next year in Glasgow. Sunny Glasgow. Thank you very much, guys.
Thank you.